Welcome to Wisdom Radio. I'm Dr. Rusty Hofmann, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started. Stay tuned to my commentary at the end of this podcast, as I really do not agree with the conclusions of this study. In particular, anticoagulation did not improve stent patency. Enjoy listening to the pod, and I'll see you on the backside.
Today we're doing a deep dive into a cohort of pancreatic cancer patients where their portal vein stents are clotting off in 48 hours. And we really have to ask a challenging question for you in the cath lab. Does tumor biology basically eat our pharmacology for breakfast?
That is the central tension we're exploring today. Because in interventional practice, we're conditioned to just reach for the prescription pad to solve early stent thrombosis.
Right, exactly.
We just assume that if we thin the blood enough, the metal will stay patent. But the data we are reviewing today suggests that if the flow dynamics and that local inflammatory microenvironment are hostile enough, well, your direct oral anticoagulant may not save that stent.
Which brings us to the mission of our deep dive today. So we're breaking down a 2026 JVIR retrospective cohort study by Bretzman et al. Out of the Mayo Clinic. And they analyzed portal vein stent placement, specifically in a pancreatic cancer cohort, evaluating 182 patients.
Yeah, which is a really solid number for this.
It is, yeah. So they're attempting to answer a core clinical question for you. When you're dealing with these malignant portal occlusions, what actually predicts early stent failure? And maybe more importantly for your everyday practice, does routine anticoagulation actually keep these stents open, or are we just treating our own anxiety?
To answer that, we first need to establish the baseline reality of this patient population, because you just can't evaluate the performance of a medical device without understanding the physiologic environment it's actually sitting in.
Oh, absolutely.
So we are looking at 182 subjects, and all of them have pancreatic adenocarcinoma. And, that diagnosis alone tells you this is a prothrombotic malignancy.
And the authors actually broke the cohort down by clinical intent, which I thought was interesting. They had 11 patients who were pre-resection, 92 were post-resection, and 79 were palliative. And honestly, the survival data they report grounds this entire discussion. The median survival for this cohort was just 9 months, with a 36.3% mortality rate just during the follow-up period.
It's sobering.
It really is. The stent is basically just a mechanical intervention deployed into this rapidly progressive systemic disease.
Exactly. And that survival data frames the clinical expectation. The biology of the cancer itself is really the dominant force here. And we actually see that reflected in the patency outcomes based on the indication for the procedure.
Right, because looking at those different indications, my initial assumption was, I assumed placing a stent to optimize a patient pre-surgically would naturally yield better patency rates than placing one purely for palliative decompression.
Sure, yeah, that makes intuitive sense.
Right. You'd think the pre-resection patients might be earlier in their disease course and therefore just have a less hostile venous environment, but the data shows something different.
It really does. So whether the patient was pre-surgical, post-surgical, or palliative, they stated no statistically significant difference in stent patency.
Wow.
Yeah, the hazard ratios all just hovered right around 1. And I think this highlights a biological principle for you to remember. The disease does not care about your clinical intent.
No, it really doesn't.
The tumor biology and the regional hemodynamics overshadow the reason you brought the patient to the table in the first place. The stent only responds to the physical flow and the thrombotic state of the vessel.
Okay, so let's examine the concrete procedural details then.
Yeah.
Given how aggressive this malignancy is, I want to break down exactly what hardware and techniques the Mayo Clinic operators utilized.
Yeah, let's get into the weeds a bit.
So they used a percutaneous transhepatic approach for access. And upon completion of the procedure, they deployed Nestor coils in the transhepatic tract for hemostasis, which, that aligns with standard practice considering these patients are often coagulopathic and obviously at high risk for bleeding complications from a transhepatic puncture.
Right, but they also added a really practical clinical step. They injected 0.25% bupivacaine at the liver capsule for analgesia.
Oh, interesting.
Yeah, it is an addition for locoregional pain control, particularly when you're aggressively dilating the portal system. And for the angioplasty itself, the operators primarily utilized 10 millimeter, 12 millimeter, and 14 millimeter Atlas balloons.
Which brings up a really interesting mechanical consideration regarding balloon sizing in a malignant stricture. You're balancing the need to establish a functional lumen against the risk of causing endothelial injury in a bed that is already inflamed.
Absolutely, it's a tightrope walk.
Yeah. And the stent choices reflect that same mechanical debate. They used a mixture of devices based on operator discretion. So they used Protégé, which are self-expanding bare metal stents. They used VisiPro, which are balloon-mounted bare metal. And then the Viabon VBX, which are covered balloon-mounted stents.
And the distribution of those stents is where the data starts to really challenge our conventional mechanical assumptions.
Exactly. Looking at the hardware breakdown, I was shocked. Only 12.6% of the stents deployed in this cohort were actually covered.
Yeah, it's a really low number.
I mean, if you think about TIPS procedures, or really any malignant venous recanalization where extrinsic compression and tumor ingrowth are your primary concerns, the instinct is to put a physical barrier between the tumor and the lumen.
Right, you want to line the pipe.
Yeah. Why not just use covered stents by default here? My immediate assumption would be that a PTFE covered stent is mandatory to maintain patency against an invasive pancreatic mass.
It is a logical assumption based on basic structural engineering principles, but the data from this paper contradicts that structural logic.
Really?
Yeah. When the authors compared the outcomes of covered stents versus bare metal stents, the odds ratio for failure was 1.54 with a p-value of 0.379.
There was no statistically significant patency benefit to justify the use of covered stents in this specific environment.
And furthermore, they evaluated residual stenosis. They found that a residual stenosis of greater than 30% after stenting didn't significantly correlate with stent failure either.
Wait, really? So leaving nearly a third of the vessel narrow doesn't doom the stent.
Yeah.
And deploying a PTFE cover over the struts doesn't save it.
Exactly.
That forces a complete reevaluation of the actual failure mechanics. If the failure isn't primarily driven by structural tumor ingrowth over time, and it's not driven by immediate elastic recoil from residual stenosis, then we are misunderstanding the enemy here.
Yes.
It's not a hardware failure. It's a biological failure, which I guess brings us directly to the timeline of these occlusions. So there was a 74.6% patency rate at a median follow-up of 12.2 months. So this means roughly 3/4 of these stents maintain patency at 1 year. But for the quarter that do fail, the timing of that failure is probably the most telling data point in the entire study.
The median time to occlusion for the failed stents is a mere 2 days.
2 days. That timeline is defining. When these stents go down, they go down immediately. This rules out late intimal hypoplasia. It rules out slow, progressive tumor ingrowth over weeks or months. This is an acute thrombotic event occurring before the patient even leaves the hospital or, shortly after discharge.
Right. And understanding that it is an acute day 2 thrombosis allows us to look at the predictive factors in a different light. So in Table 4, the authors detail the multivariate predictors of stent occlusion.
Okay, let's look at those.
The first major predictor is pre-intervention complete portal vein occlusion, which carries an odds ratio of 2.84 and a p-value of 0.017.
Physiologically, that makes sense. A complete occlusion dictates a lack of forward flow prior to the intervention. You are dealing with a heavier burden of established organized thrombus compared to, say, a simple focal flow-limiting stenosis.
Exactly. And the second major predictor identified in the multivariate analysis is periportal inflammation, carrying an odds ratio of 2.61 and a p-value of 0.025.
Ah, okay.
And this introduces the concept the authors refer to as immunothrombosis.
Yes, this concept of immunothrombosis is central to interpreting this paper. The authors are saying that the local inflammatory state is driving the coagulation cascade.
Right.
The inflammatory milieu of the pancreatic tumor is hyperactive, and it's releasing cytokines and tissue factor that activate platelets right at the site of your mechanical intervention.
Precisely.
You're not just pushing metal into a narrowed tube, you are deploying a foreign body into a bed of localized active thrombosis.
And that biological hyperactivity, you can actually see it visibly on cross-sectional imaging.
Really?
Yeah, the presence of perivascular inflammation, which is often seen as fat stranding around the portal structures on a pre-procedural CT, that's a direct marker of this process.
Okay, so this is a practice-altering takeaway for you when you're reviewing cases in a multidisciplinary tumor board. Tomorrow, when you look at a pre-op scan for one of these patients, you aren't merely measuring the vessel diameter to select your balloon size.
No, not at all.
You need to grade the biological hostility of the surrounding tissue. If you see severe periportal inflammation, you are looking at a predictor that the stent you place is at high risk of thrombosing within 48 hours.
And beyond the inflammation, there's a critical hemodynamic warning sign that was highlighted in the univariate analysis.
What's that?
The presence of robust collaterals. Persistent robust collaterals after stenting demonstrated an odds ratio of 3.85 for occlusion.
Wow, 3.85. But if you think about the fluid dynamics here, it tracks. If you have robust collaterals, stenting the main portal vein is like opening a new highway lane but leaving the detour signs up.
That's a great way to put it.
Right. The blood just continues to take the path of least resistance that it's already accustomed to. If the pressure gradient favors the very seasoned collaterals, the flow is just going to route right around your newly deployed stent.
And that stagnant flow is the catalyst for failure. If you have low flow through a bare metal stent in an inflammatory prothrombotic patient, well, that blood is going to stagnate and thrombose quickly.
It has to.
It is the definitive proof that just resolving the anatomical stricture doesn't always resolve the regional hemodynamics.
Right. So if acute thrombosis at day 2 is the primary failure mode and it's driven by stagnant flow and immunothrombosis, the natural clinical response is pharmacologic.
Right.
If you know a stent has a high probability of going down in 48 hours, the instinct is to escalate antithrombotic therapy. Which brings us to the most debated finding of this retrospective review. Does anticoagulation actually prevent this acute failure?
Well, Table 1 details the pharmacologic management of the cohort. Post-procedure, 74.7% of the patients were maintained on anticoagulation, and it was overwhelmingly with apixaban.
Yet the statistical analysis showed no association with stent patency. The odds ratio for anticoagulation preventing stent failure was 1.13 with a non-significant p-value of 0.768.
Yeah, it's wild.
And additionally, there was no statistically significant difference in major bleeding events between the groups. It was 17.6% for those on anticoagulation versus 21.7% for those without.
You know, this lack of efficacy for direct oral anticoagulants in preserving venous stent patency really mirrors data we are analyzing in other venous beds.
Though, like what?
Consider the REVIT trial, which investigated post-thrombotic syndrome in the iliofemoral system. That trial demonstrated that intensifying antithrombotic therapy by adding aspirin to rivaroxaban didn't improve stent patency. It merely increased the rate of bleeding complications.
Right.
We are seeing a consistent principle emerge across the venous stenting literature. Venous flow dynamics require adequate physical volume and pressure, not just chemically altered, less coagulable blood.
Yeah, while that principle definitely aligns with broader venous data, I think we have to critically evaluate the study design here, because relying on a retrospective headline conclusion can be pretty perilous.
Oh, absolutely.
There are methodological limitations in this paper that require an honest critique.
Yeah, the retrospective nature of the study introduces some inherent structural flaws. And the most prominent issue involves how the anticoagulation protocol was actually managed.
Right. Because midway through the study period, the Mayo Clinic implemented a standardized DOAG protocol for these specific patients.
Right, exactly.
As a result, the no anticoagulation control group isn't a randomized parallel arm. It's a distinct minority composed heavily of patients from the earlier years of the study, and this is key, patients who were actively bleeding or had severe contraindications and were therefore excluded from the DOAG protocol.
Yeah, and that creates a selection bias. If the only patients not receiving anticoagulation are your highest risk bleeding patients or those with differing baseline characteristics from an earlier era, well, you're not evaluating a clean, isolated variable. There's also the limitation of the surveillance strategy. The follow-up was largely imaging-based, relying on CT or ultrasound performed for just routine oncology staging, or it was triggered by a symptom-driven clinical decline.
Right, which means the surveillance strategy can easily miss asymptomatic non-occlusive thrombus. A patient might develop a 50% mural thrombus inside their stent on day 3, but if they aren't clinically crashing and don't have a routine oncology scan scheduled for another 2 months, that event does not get captured as an early failure.
Exactly.
Therefore, you really can't confidently declare anticoagulation entirely useless when your control group is heavily confounded, you are ignoring antiplatelet therapy, and your surveillance method is intermittent.
I agree, the critique is necessary, and the conclusion regarding pharmacology certainly stretches the limits of this retrospective data. However, even accounting for those structural flaws, the central thesis remains completely consistent with established hemodynamic principles.
Which is?
Correcting the inflow, ensuring adequate outflow, and overcoming the local flow dynamics matter far more than the intensity of the systemic blood thinner. If a patient presents with complete pre-intervention occlusion, severe periportal inflammation, and persistent collaterals, prescribing apixaban is just not going to override that biology.
No, it won't.
The hemodynamics and the local inflammatory state will always dictate the outcome.
Before we wrap up, this data leaves you with a really lingering thought regarding the future of these interventions. If local immunothrombosis and immediate platelet activation at the stent struts are the true mechanisms of failure in these pancreatic masses, perhaps we're just relying on the wrong pharmacologic strategy entirely.
Oh, for sure.
It suggests the future of malignant venous recanalization might not lie in systemic oral anticoagulants, but rather in the development of drug-eluting venous stents coated with localized immunosuppressants or potent anti-inflammatories designed specifically to neutralize that tumor microenvironment.
Now, that would be fascinating. But for now, if this paper is correct, you might reconsider aggressively escalating anticoagulation to maintain portal stent patency in a patient with a high bleeding risk and poor underlying hemodynamics. That's all for today. Thanks for listening.
This is Rusty Hofmann. I'd like to congratulate the authors from the Mayo Clinic, but I would really like to just highlight a couple of things. Due to the retrospective nature, the data is pretty heterogeneous. And in particular, they're grouping all anticoagulation into whether you were on a blood thinner or not. Specifically, about 45% of the patients were on prophylactic dose of a DOAC or enoxaparin. When I have done these cases at Stanford, we do full anticoagulation. We do not believe in prophylactic dosing, especially in cancer patients that have pancreatic cancer. Next, pancreatic cancer and GBM are two of the most thrombogenic tumors that you can have. And specifically, the NCCN guidelines recommend that patients with GI cancers, of which pancreatic cancer is one of them, is that you use enoxaparin. So enoxaparin full dose, 1 milligram per kilogram BID is what we would routinely use at Stanford. I've not looked at our experience, but what concerns me is the acute occlusion with medium time to occlusion was 2 days, with the interquartile range to be between 0.7 and 5.3 days. What was not mentioned in the paper is that pancreatic cancer and GBM and other GI cancers have high incidence of tissue factor. Tissue factor is perhaps the most thrombogenic substance on the planet, and it causes thrombosis in two ways. One, if tissue factor from the tumor is directly exposed to the bloodstream, it will cause coagulation. Two, there are microvesicles that are secreted from the tumor, and these vesicles can cause peripheral thrombosis, and that's why there's this high incidence in the tumors we have discussed. So what I believe to be true is that if there is direct invasion by pancreatic cancer into these vessels, tissue factor is exposed and there is thrombosis immediately. I do believe that the two best ways to treat this are one, with 1 milligram per kilogram of enoxaparin, and number two is actually using a covered stent. The authors only had 12.6% stents that were covered, and they said that it was a predictor that there was thrombosis. However, they don't say what degree of anticoagulation those covered stents received. And it's a small retrospective cohort within this larger paper. So I guess my take home on this is that this is really a tumor biology issue mediated by tissue factor from direct invasion into the vessels, given the acute thrombosis that occur in 2 days. I would recommend personally 1 milligram per kilogram of enoxaparin, and consider using a covered stent if you can, if you're not going to jail off, an important splanchnic venous structure. This has been my experience over my career in stenting through tumors, but I think that stating that anticoagulation did not improve stent patency, which is in the conclusion of this paper, is a little overstated in my opinion, given that not all anticoagulation is created equal. One, we talked about dosing, that prophylactic dose versus full dose. And two, the type of drug that you could use We would use enoxaparin over DOAC as that complies with the guidelines. And also there is data that supports, as the authors discuss about inflammation, that the heparinoid has anti-inflammatory properties. So thank you for listening. This is Dr. Rusty Hofmann, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.